Good afternoon to everyone. Thank you very much for joining us in this webinar. As you know, this webinar is part of a series of webinars organized under the frame of the COVID-19 pandemic. The aim of this webinar is to use the expertise, the knowledge, and the real, very particular input coming from the experts working in the European Reference Network system in areas where having at the same time the particular condition that the network is addressing, like in this case, the rare connective tissue and musculoskeletal disease and condition could affect or could have an interaction with the COVID-19 infection. What things to do, what things to prevent. For this, we have today the privilege to have two main experts. One is a patient who is really the expert on the disease, who will explain us from her perspective what are the real important issues to take in account. And Ilaria Galetti, she is the representative of the European Federation for Systemic Sclerosis, and she is very much involved in the European Reference Network ReCONNET, as she is one of the patient representatives in the network, and it's working in many domains, many areas together with the clinician, the healthcare professionals, etc. And we have after her Professor Marta Mosca. Professor Marta Mosca is a rheumatologist. She is working in the Hacienda Hospitalaria Universitaria Pisana, and she is the chief of the rheumatology unit and is the coordinator of the European Reference Networks ReCONNET on these diseases. I am Enrique Terol. I am a functionary of the European Commission. I am working on European Reference Networks since a while, and I will give you also some information about the logistics. First of all, during the webinar, you will be muted. That's to avoid noises and echoes, etc. You know that. But we encourage you to interact as much as possible with the speakers and with the whole audience. You have two ways of doing it. Either using the chat, you will see that you have a chat functionality. You can click on the chat, and then here we invite you to include comments or information that you would like to share in general with the audience, with the public, or if you have any kind of technical problem. We will try to support you on that. And then you will have the question and answer tab. You will see that in your right-hand side at the bottom, Q&A, where you can put direct questions addressing the speakers and the host, and which will be the way that we can identify that easily, and we will, after the presentation, put these questions in the screen so that Marta and Ilaria, they can come back to you and we can have a discussion about this. This workshop will be recorded, so that's the reason that we will not put your names in the screens for the questions. So because otherwise we will need to follow a quite explicit informed consent process, and all the recording of this meeting, the presentations, and all the information will be published in the webpage of the Commission, and you will receive also a communication with the links to this. So after, just to finalize, just to tell you that after the webinar, once you close your application, will appear a survey, a short survey. We ask you please to fill the survey because it's very important for us to know your opinion on the interest of the webinar and also on the technical details related with your capacity to listen or to see appropriately. So nothing else to say, and now it's my honor to invite Ilaria Galetti to start her presentation. So I give you, Ilaria, now the role as presenter. so that you can share your screen.
Enrique, but I would like you to use my slides.
Okay,
please.
then I give you you have just to share your slides and we'll appear.
No, I sent them this morning.
Okay, you want me to pass yours?
Yes, please, because I had technical issues.
Okay. We
just
will.
before starting.
Okay.
In the meanwhile, let me thank you for this great opportunity to make the voice of patients heard, mostly in this very difficult situation, which made us be even more united. We felt all part of a great family. The rare and complex disease patients already felt a strong family. But this pandemic helped us to live all together, to share the same difficulties, the same isolation, the same fears, and that made us even more stronger and unique. So being here today on behalf, I think, of the 30 million rare disease patients, not only of the patients belonging to ReCONNET, is a great honor, but also a great responsibility. So thank you very much to give us patients this opportunity.
I'm almost there.
Well, no problem, Enrique, no problem. You already introduced myself. My name is Ilaria Galetti. I belong to ERN ReCONNET, which is the network on rare and complex rare connective tissue musculoskeletal diseases. The ReCONNET is a small network, just 10 diseases, the rare diseases, the complex, and the hereditary condition. We must say we share some common problems which made us be here today facing this situation. First of all is the pulmonary involvement, the interstitial lung disease and the lung fibrosis. What we have seen in COVID-19 is common in our diseases, and also the use of immunosuppressive drugs, which made us be very scared when we heard about the COVID-19 at the end of February, because maybe it's true, maybe it's not true, but we thought, okay, our immune system doesn't work very well. We feel more vulnerable, more weak than common people. Thank you, Enrique. Thank you very much. And you can go to the first slide, please. And this made us be willing to self-isolate ourselves, because we did the same during the flu in winter. We already take protections. We wear masks. We use the hydroalcoholic gel to clean our hands to protect from bacteria and from simple viruses. And we, as the conditions affect the musculoskeletal system, we need to make physiotherapy and rehabilitation. And we also need to go regularly to the hospital, both for normal visits and also for pharmacological therapies, which are mainly infusions. And in the next slide, we see that ReCONNET is a wonderful infrastructure. And as you can see today, patients are always first. I talked before Professor Mosca, and this is normal in ReCONNET. It's not extraordinary just because today we are at with the European plataea. And patients, of course, are the core of ReCONNET, as for the other 24 ERNs. And the EPACs, which are the representatives of the wider community, are the mean to an end. An end is the end of this bridge, of this infrastructure, which is a better health, a better care, a better cure, and an equal access to patients all over Europe. In the next slide, you will see my colleagues, which are my friends, and are the EPACs that cover the 10 diseases. We have Silvia representing antiphospholipid syndrome, Alan representing lupus, Charissa and Jürgen, they both represent Ehlers-Danlos syndrome. Vera, the smiling girl, she represents mixed connective tissue diseases. From England, Lisa, which will be even more precious in the next time. Anna from Portugal represents Sjogren's syndrome. And Lisa represents relapsing polychondritis, a very rare condition. Next slide, Enrique, please. So we already spoke about the lung involvement, the immunosuppressed therapies, and the voluntary lockdown that had of course, as for all the other people in the world, a high impact and on the social and physiosocial well-being. The next one. We already heard last week during EURORDIS webinar that many hospitals was transformed into COVID units, especially in countries where the virus was more aggressive. I come from the purple zone, I can say Lombardy, and all the hospitals were COVID units. And many rheumatologists had to help their colleagues in the management of some therapies that were used for rheumatological conditions, and now for the treatment of COVID-19. One of them is tocilizumab. And sometimes in some countries, the lack of protective equipment like masks or gloves or even hydroxy alcohol prevent our patients to leave their homes and go to the hospital or even to the supermarket, for instance. And again, talking again in the next slide about disruption or discontinuity of care, which was common all over Europe. I wrote here that this discontinuity of care could have led to flares. I think I should have written have led to flares of the disease, and maybe Professor Mosca could be more explicit on this, but also in the delay of diagnosis of the disease and diagnosis of organ damage. And I think we will see the consequences of this disruption of care in the next month, in the next year, and will have a high impact on the health, of course, of patients, on their quality of life, on their psychological well-being, and also in the economic situation of the families. Sometimes home care was not has not been performed because as we have collected the inputs from our communities, physiotherapists could not enter the house of our patients because they could not protect themselves and as well as the patients. The following point, in our opinion, is really important. We know it happened. We are a vulnerable population. And we believe that the vulnerable ones should have the right, have had the right, and have the right to be tested if exposed to COVID-19. In some countries and regions, depending on the healthcare system, this didn't happen, putting at a very high risk some people. We already said that there is a serious pulmonary involvement. So we believe that vulnerable people should be, their rights should be respected. The next one, please. I wanted to include, because there was a discussion with my IPAC group about the misinformation, which is only a wrong information given not with the aim to cause any harm, any fear, any damage. At the beginning, we heard that hydroxychloroquine or chloroquine could be the right and very cheap drug to treat COVID-19. That was just a misinformation because we didn't have real data to say it was not true. But this led to a, not technically, we can't talk about a shortage, but to tension and supply discontinuation in several countries. This means that our patients affected by antiphospholipid syndrome, mixed connective tissue disease, Sjogren, and lupus could not have access to this therapy in hospital or local pharmacies. But then, of course, as always happens, we have many examples of disinformation and fake news, and this disinformation, is meant to cause harm and biased news. And for a non-scientific population, which are patients and common people, in such a pandemic situation, searching everywhere for any kind of news and reading maybe that the disease could be cured with some foods or beverages, that was really dangerous. Please, the next one. The psychological and psychosocial impact. Please note that we enter in very detailed work because Vera, one of our EPAG, she's an expert. She works on that and she provides very good points. So as we said, the lockdown had a strong impact on every person spread all over the world, but the different national or even regional actions and guides made the European community very disoriented because we, EPAG, the 24 ERNs, EPAGs, we are a very strong community. We are in contact, but we have behind other networks which are very wide. So we share information, and we couldn't understand why one country or one region took some decisions and other didn't, even within the same country. So this creates lots of anxiety. But we have also seen that the teleworking have been implemented, even if it's not guaranteed in some countries where the lockdown ended. And this had a positive impact, the teleworking, on the psychological situation of the patients. And also teleconsultations. They were necessary because clinicians were involved in COVID units, and they helped in the management of the disease itself, of course, but also on the psychological aspect, because the patients' organization, they played a great role in this, enabling teleconsultation with psychologists. It was not easy because maybe they didn't have the instrument, but they made a great job. The next one, Enrique, please. So we have seen until now, let's say, the bad things that we had to face. But we think that we can learn from what we have been living in the next months and find something good to make it, to implement in the future. And now we can see new strategies that we think can be very useful to maintain and implement in the next slide. So we spoke about disruption and discontinuity. We see that the patient that had to go to the hospital through the emergency room, they were separate. COVID patients, non-COVID patients, which is, of course, fantastic. And we were thinking before the pandemic that for immunosuppressed patients, which are not only rare connective tissue disease patients, but a lot of them are weak patients, elder persons, to maintain the safe access could be an opportunity. And also implement home therapies, if provided that efficacy and safety are guaranteed for patients. It was possible during this month. Why not to keep also this good practice? And also the implementation of teleconsultations in agreement with patients. I think that as our diseases made patients not to expose themselves to cold temperatures because of Raynaud phenomenon, why not to have a face-to-face visit, and then in winter time, when winter with cold temperatures, switch in teleconsultation. But we also need a very secure platform. The ideal, it would be a common platform. We already have an example in the 24 ERNs. Of course, we don't believe that it would be possible to use the CPMS, but such a platform is possible. And we believe that the safety of the data managed by the EU, it will be a guarantee. And the involvement of patients that we have seen in the monitoring of shortages, hydroxychloroquine, chloroquine, and other therapies could be maintained. EURORDIS has made a great, huge work in this month. Really, really amazing. They produce, I can say we produce, because we are part of EURORDIS. We produce many statements to policymakers or other stakeholders, and documents on products in development of therapies for COVID-19, which were weekly updated. So, and they were complete because they took into account all the stakeholders. So let's keep it not only in EURORDIS, but also on other levels. And in the next slide, we will see other opportunities, because we talk disinformation, fake news. We got a lot of information coming from the European societies, from the national societies, from the hospital, from the disease specific. We think that a clear, simple, and centralized information would avoid any fragmentation and contradictions as well. And this is what ReCONNET did in a small, in our small world, because as always, Marta Mosca says, we don't want to reinvent the wheel. We use our network, and in our network, there are professors working in La Filière Française, which is I think everybody in the rare disease knows La Filière, and they produced the FAIR to the recommendation for the management of autoimmune and autoinflammatory diseases. And we thought it was a great work, and we endorsed them. And the EPAGs decided to translate them in 19 languages, engaging their communities of patients spread around Europe. And in a relative quick time, we could provide our communities these recommendations that said the same thing with the same template, changing just the language. And also, ReCONNET with an EPAG, the coordinator with an EPAG, was presented at the webinar on COVID-19 at Istituto Superiore di Sanità with Dr. Domenica Taruscio. And the last slide is that, again, the fragmentation of decisions, actions, and guides. Maybe because I'm very sensible on this, according to the place where I live, where many people died, and we were very disoriented. Or maybe because I am a fan of ERNs and our word, and we would really welcome a common guidelines. I mean, not only ReCONNET, but all ERNs, and of course the EU. And implementing the teleworking, but always remember to guarantee the rights of patients, so in accordance with the employee and the employer. And a good practice that we had in some countries, that hospital medicine were delivered at home or in local pharmacies. It would be very useful, and all these best practices would have a great impact on the health of patients. The less we go to hospital, the better, and this is the great lesson we will take from COVID pandemic, and on our well-being for our families. And we also have to consider the direct and indirect costs for patients and for the healthcare, national healthcare. A good balance of all of this. And finally, I would like to close with the words of, in the next slide, of a great poet and writer that we lost because of COVID-19. And he summarizes in these words the reason why we are all here, because we had a dream, and the dreams are the core of our lives. And we are obstinate, stubborn, and resistant, and we will never give up, because our aim is to finish the bridge, the infrastructure, to make it work for the patient community. And I would like to thank you all.
Thank you very much, Ilaria. That was great. And I will say that you have mentioned something that is very, very important, and you have identified many elements related with this. Probably we will discuss that later, is how the healthcare system should be transformed and learn from this experience, no, in many different elements, dimensions, no? And I think that's fundamental, that we are not missing now the momentum to do it, no? Not to forget in the next months, okay, we are coming to the normality back, but I think it's really, really very, very interesting what you have mentioned. And now I will pass the role of presenter to Marta. You will, if you can share your screen.
So thank you very much for giving us this opportunity. Ilaria, I'm never ever going to talk after you again. This is the last time, I swear. So it's a big opportunity to share with you some medical issues raised by this pandemic. I'm Marta Mosca, I'm a rheumatologist. I work in Pisa, and I coordinate the ERN ReCONNET, as it has already been said. What I'm going to do in the next 15 to 20 minutes is to try to focus on some medical issues which were raised, and Ilaria has already discussed some of these. The beginning of the pandemic has been really scary because we didn't know what to do. We didn't know much about the virus. We didn't know much about the disease and how to treat the disease. And we had so many questions, and we didn't have any answer. So all the questions that Ilaria has raised, we didn't know what to say. And this was really, really very difficult for us. So what I'm trying to do is to tell what we've learned. This is the structure of what I'm going to discuss, which are the clinical issues related with the coronavirus infection, the impact on clinical management, on the organization of care, what we've done, but Ilaria has already covered that, so it will be very fast, and what we've learned. As Ilaria has already anticipated, ReCONNET is a network covering the rare and complex connective tissue and musculoskeletal diseases. And the diseases are those you can see here. So we have rare connective tissue diseases, and these are mainly systemic autoimmune diseases, complex connective tissue diseases, again, systemic autoimmune diseases, and rare hereditary connective tissue syndromes, basically the Ehlers-Danlos syndromes. These conditions have common characteristics. All these diseases are chronic diseases. Patients have a wide variability of clinical manifestations. We've heard about lung involvement, which actually was very important because the coronavirus infection also has a pulmonary involvement. Patients with these conditions may develop damage, may have comorbidities, and we will learn how this is important in this setting. Obviously, we know that this has an impact on quality of life. These conditions have a diagnostic delay. The treatment of these diseases is very complex and is mainly based on the use of steroids and immunosuppressive drugs and biotechnological therapies, which now have been discussed a lot because many of these treatments have been used to treat patients with COVID-19, so it has been an issue during this pandemic. So the clinical issues. As Ilaria anticipated, lots of questions arise at the beginning of the pandemic because we didn't know what was the scenario, what the scenario would have been and what to suggest to our patients. And mainly the questions we had to face as far as the clinical part is concerned was whether patients had a higher risk of contracting the coronavirus, whether they had a worse prognosis in case of infection, and basically because of the comorbidities, the disease itself and the treatment. We didn't know anything about that, so we tried to have answers. Now, I can tell you what we know today, because we didn't know that at the beginning. We know now, and this is very important, because now we're entering a phase in which we have to live with the virus, because the virus has not been beaten. The pandemic has been, let's say, beaten, but we have coronavirus with us, so we need to know all this. So what we know about the risk of contracting coronavirus, we know about from phone surveys, which have been done by many groups by talking with patients by phone. So we have different data. These are data from Regione Veneto, and this data suggests that the proportion of patients who got the infection is very similar to that observed in the general population of the Veneto region. So apparently no higher risk of contracting the infection. In our cohort, we had a slightly different experience. We interviewed 1,000 patients followed at the Pisa Uni. And as you can see, a lot of these patients were actually patients with the disease covered by ReCONNET, lupus, Sjogren, antiphospholipid syndrome, inflammatory myopathies. And what we have learned is that the infection was a little bit more common about CTD patients than in the general Italian population, as we've known that about 1.2% of these patients contracted the infection versus the numbers we have from the Italian data now. About the disease expression in patients with rare and complex diseases, connective tissue and musculoskeletal diseases, we as a ERN have decided not to go for a registry because we already had registries from the scientific society. As Ilaria said, we do not want to reinvent the wheel, so we waited for the data of these registries. Actually, we have an Italian registry, then we have a European registry, but all these registries go into a global alliance registry. So what I'm going to do is to show you the data of this final registry. So this is the publication. This registry has so far included 600 cases from 40 countries, And we know that of those patients who got the infection, about half of them needed to be hospitalized. 9% of these patients died for the infection, and these are the more common conditions. Again, as you can see, there are patients with rare and complex diseases. But what's very interesting is that the data from the registry suggests that the rheumatic disease per se, it is not a risk factor of a more severe disease. Rather, the comorbidities, which we know are a risk factor for everyone, are the risk factor for these patients. So we can see the thing in a different way. Since I have a disease, and in my disease I have a higher incidence of comorbidities, this is the reason why I might be at risk. So this is what Ilaria was saying. I have lung involvement because of the disease, and then I might be at risk because I have a lung involvement or I have hypertension, but not just because I have the disease, but because of the disease expression. So in the end, having systemic sclerosis or lupus, if the disease is very well controlled and there are no comorbidities, is apparently not increasing the risk. But if I have a severe disease, then I might be at higher risk of having complication of the infection. So the disease per se, it is not an adjunctive risk factor for infection. And this is really good information for patients because it makes the thing a little bit less scary, and it allows us to define different risk profiles for the future for our patients. The impact on clinical management. The impact of clinical management, it has been huge. And Ilaria has already anticipated many of the issues we have faced. Here at ReCONNET, we have tried to understand from our healthcare providers what was on their mind, which were in their minds the major clinical challenges faced during this period. Because by knowing this, then we could try to understand what to do in the future. So we ran a survey to understand this. We very straightforward questions, very easy questions to understand. As you can see, 70% of the problems were the limitation of the diagnostic and routine monitoring of patients, the difficulty of having face-to-face evaluation, the need to change the way we give treatment. For example, tocilizumab, it's a treatment which is administered either IV or subcutaneously, and we decided to switch patients to subcutaneous administration for many reasons, and this was a problem. If you go down on this table, then you can see that other problems faced were managing the risk of infection in patients treated with immunosuppressive therapies, as patients with connective tissue diseases are, the management of risk of infection, the relapse of the disease due, for example, to the decision which many patients took to stop their treatment. So I think that the difficulties that we faced was to try and to find a way to monitor patients without a face-to-face evaluation. Telemedicine is an opportunity, but as a doctor, I have to say, it is not easy. It is not easy, and you have to know very well the patient you are seeing on a video to be very sure what you're saying and what you're doing. So it requires a lot of learning for doctors. It's not as easy as one might imagine. On an organizational point of view, which were the preventive measures to be proposed to our patients? The same preventive measures as advised the general population should be advised to the patients with rare and complex connective tissue diseases, but there is also the opportunity to assess a specific risk based on the treatment and on comorbidities, as I was saying. What I didn't say is that apparently among the immunosuppressive treatments which are taken by our patients, those who increase the risk of having a problem if getting the infection are steroids more than other treatments. So this should be considered when assessing a specific risk. This scoring system has been proposed in the UK and allows the stratification of patients with autoimmune rheumatic diseases, as you can see with a score. And here you can see that a dose of steroids above 20 milligrams per day for more than 4 weeks is considered to carry a high risk for patients. So this should be considered when advising shielding, when advising teleworking and staying at home, and different levels of shielding for patients, as well as cyclophosphamide, but also, as I was saying, the comorbidities, age, diabetes, lung disease, renal impairment, which we know are more common among patients with rare and complex connective and musculoskeletal disease. As you can see, there are drugs which are safe, as hydroxychloroquine and sulfasalazine, 0 point. So these treatments should be continued for our patients with no fear. Based on the data which have been collected over these weeks, I would say, provisional recommendations have been published by the two scientific communities, EULAR, the European, and the American College of Rheumatology. I'm just briefly going to tell you what they tell us. In patients with the contact with COVID-19, what to do? Because this is the other big question. What should I do if I was in contact with someone? Should I stop my treatment? Will I be at risk? So the message is not to stop anything and to contact your doctor. This is the first message. But then to continue chronic steroids, because it's more harmful to stop chronic steroids rather than continuing. To continue hydroxychloroquine and sulfasalazine. And there are differences in the recommendations, whether to continue treatment or consider temporary stopping of immunosuppressive therapy. So my message for the patients who are listening to us today is to talk to their doctors, because doctors may take decisions based on the single patient. It's not a general rule. We have to discuss about the situation of the specific patient. Both decisions might be taken, and both decisions will be based on a condition and decision based on the patient. What if I have, or I might have, the infection? Then, again, steroids low dose, hydroxychloroquine should be continued. And again, the decision on whether stopping immunosuppressive treatment or not should be discussed with the physician. Personally, I advised stopping immunosuppressive treatment to those patients I was in contact and when I was sure they got the infection, as I do when they suspect flu or other infection outside the coronavirus pandemic. The impact on the organization of care, again, this is our survey, and here the question is different. The first one was the clinical, so the other one was the organization, because it's slightly, it might appear the same thing, but it is not. So obviously, we had to reinvent the way we were giving care to our patients. We had to find a different way to give IV treatment to be sure that those patients coming to the clinic were not at risk of getting the infection, because the hospital were felt as the most dangerous place in the world during pandemic. I don't want to go in the hospital because I'm going to get coronavirus if I go there. So we had to reinvent how to make everyone safe in the hospital. The patient flow, which we have to organize now because we are going back to a different normal life. So we need to be sure that everything is done in a safe way. As you can see here again in this table, you will have time to review it in the recorded webinar. Then you'll see that is the prioritization of the essential services, for example, has to be really here and who can be taken care by telemedicine. This has to be decided, and it's not easy. We had to organize everything for telemedicine because we weren't used to do that. So the computer, the links, the sure platforms to do that. So all the things we had to organize, and this had a big impact. And it has to be organized. It had to be organized in 1 week, 2 weeks, a few days. So it was really fast, and it was difficult for them. But as Ilaria said, this is a big opportunity because I think it's going to teach us lots of things and change the way we were doing things. We know that we change our behavior very slowly because we feel that the way we have done things it's the right one because it has been the right one for years, decades. But now we had to change, and maybe we will learn something. And even when coronavirus will be beaten, we have a vaccine and we will be free, then maybe we will keep something we have learned. We will ensure adequate resources, and we will learn for other things. What have we done? Ilaria has already told you lots of things we have done together, patients have done, and we obviously have prepared a section on our website. Now everything is virtual, everything is website. I have two girls at school was websites and was teaching, and so everything has changed. And so everyone was looking for information, and you can find that. We have endorsed the filière recommendations and translated, and our EPACs have done that in, what was that, 3 days? I don't know, maybe 3 days and 3 nights. So it has been amazing. And we have decided to move on with webinars on COVID, but also usual webinars, because life goes on and the diseases are still there. And so we try to keep something as normal as possible. And so we had some webinars, as this one we're having today, but also others. And we have worked to try to share with publication what we've learned. So the idea is that now we need to talk and to say what we know, because this will increase the knowledge of everyone, as it has done with the publication of others for us. So that's what we're doing and what we're trying to do, and to try to learn with surveys, because this, I think, will highlight differences among countries and help us to have a more homogeneous way to do. We had a very interesting webinar on sex hormones and COVID-19, and you will find the information on this webinar on our Twitter page. We've learned a lot. Yeah, we've learned. We've learned on the use of e-health and telemedicine. We have learned how to work in an emergency, and in the case this will occur, we will be prepared. So maybe second wave, we do not know, but then we have learned something. I feel that as a doctor, I've learned lots of things, even as a responsible of a unit, I think I've learned something. So let's hope we will not have to use it, but then it will make us better in our clinical practice. We've learned that we need to maintain contact with our patients, to care for them. I've learned that being the doctor who knows patients for a long time is very helpful. So I would promote a more doctor-specific care for patients. Patients have to find their doctors and be used to see the same doctors, because this makes it easier to follow them in a difficult moment. And I think that ERNs really can make a difference. Well, what happened with COVID is that we needed to talk, but ERNs were already there to talk for rare diseases. Now we talked for a strange infection, but what happened is what ERN wanted to do for rare diseases. So we need to continue this talking and learning from each other, because this is what ERN wanted to do for the rare diseases community. But the whole scientific community has done for COVID now. So I think this will actually help the work of ERNs around rare diseases. These are our contacts, just to let you know if you want to follow us, if you want to see something of the things we've discussed. And I think that I've said all I wanted to say. And I hope to have been complimentary to what Ilaria said. And thank you very much for your attention.
Thank you, Marta. It was very good. It was an excellent compliment. I know it's difficult to talk after Ilaria, but you did it quite well. So congratulations. No, I think that you have presented a very, very good overview of the situation, no? And also, this reflection about how to reorganize things and how to reinvent a bit, without reinventing the wheel, reinventing the system, no? Which is probably the challenge. So I will invite the audience to put your questions in either in the chat or in the Q&A tab. You will see that there. But meanwhile, while you warm up and you start to put questions, I will ask to both of you, to Ilaria and to Marta, How do you see the participation of the patients and the clinicians in all the process of the decision-making of the hospitals to reorganize the system? Because I suppose that has been, as you explained, something that you have to decide to intervene, to take decision every day. But have you the feeling that you were taking into account in this process?
I hope so. And to achieve this, I think it's fundamental to engage hospital managers, because without them, we couldn't create this new, let's say, safer patient pathway. And we must be taken into consideration because we bring a different perspective, a different point of view. And I mean, if they don't take a decision, it doesn't mean that it's meant on purpose. It's just because they don't know there is a problem, and the problem must be brought by patients themselves.
Yes, I agree, and I think that, again, this is an opportunity. As far as the emergency was concerned, in my hospital, they set up meetings very with all the doctors involved. So they were, I mean, it was so difficult. So they tried to listen to us, but at the beginning they had to face the emergency. Now I'm very much involved in the reorganization of the unit. So I think it's an opportunity, which I'm taking for the unit. And so, again, it's an opportunity to really listen to those who have to, forgive me, use the hospital and work in the hospital to understand how to organize better the care and the work we have. So I think that I agree that the hospital managers should be involved into that, as Ilaria said. In my reality in Pisa, I feel that we have this situation, and so I'm happy about that. Again, every place is a different story, so maybe by working on that and suggesting with EPAGs and physicians a common structure, this could help hospital managers in giving in adopting the same measures everywhere. So maybe this is a role we should have as networks working on these issues. Enrique, sorry, we don't hear you. You are muted.
Sorry. So I was just to continue this question related with something that Ilaria and Marta, you raised, both of you, is also the coordination and the integration, because it's, I mean, everyone is talking about that, but usually it's not a reality in all places with the primary healthcare services. How to integrate the work you are doing at hospital level, for example, in the sense of ensuring the provision of medicaments at home, and how do you say it? Did you have the opportunity during this crisis to interact with the primary healthcare level, or I suppose it was complicated, but how do you envisage this relation?
Ilaria, do you want to start, or I do?
If you have any experience, Marta.
So we do not. We, during the emergency at our clinic, we set up a phone and a dedicated email for patients and general practitioners. So we tried to make it public, to let everyone know that they could contact us by these means. But it was difficult because GPs were really involved in the care of COVID patients everywhere, so it was really difficult. So basically, during the emergency, patients followed at our unit were directly contacted by us. Okay, so we, in a way, probably skipped GPs. Okay, so we did a little bit of their work, but not really a lot. I mean, I don't want to say that GPs didn't work on our patients, but we tried to be useful in some way because we felt that patients were scared, were alone, they didn't know what to do, they really wanted to stay home, they didn't want to go to be bled because they didn't want to get their exams because they were scared. Now we are organizing a pilot project with GPs of our area because we need to discuss with them. We need to avoid patients going to the hospital if GPs can take care of them at home. But I think this will take time. But again, I think this will be something we will learn from and something we will actually learn and we will maintain because as a doctor taking care of complex patients, sometimes these patients are referred to us even if they have mild problems, which could be actually dealt by their GP. So we're trying to do that because they cannot come to the clinic now, but I want to keep it for the future. So we have this pilot project with our hospital and some GPs of the area. And I truly hope that this will work well, and I believe that this will work well because it will engage everyone. GPs will be able to discuss with us, which is a problem sometimes. Actually, they don't discuss with us because they don't know how to find us in the hospital. So it's kind of a wall around the hospital. And it's very difficult to get in. So we're working on that, and we will see.
Okay, that's very, very interesting also because probably it's a matter of how to use these new tools, no? Because previously it was something not to be used during the work, no? It was more, and now it's getting more and more. And in that sense, for example, which is also important in many healthcare systems, is how this type of new healthcare provision is regulated. So, I mean, when a patient is requesting you or to have a teleconsultation, how that should work, how that it's recognized, accountabilized for your activity. Also, I mean, because there are many things related, which kind of platform you should use. What's your thinking on that? Do you think that could be solved, or is you see that there is an intention also of the regulators to work on this?
Mm-hmm. Well, I think it has to be solved in a way. So, but I agree. This in the emergency, we have used what we had. So it was email. It was I've seen a comment from Anna and said in Portugal they've used Facebook and other ways. And in fact, everyone tried to find a way to be useful and to be of doctors and patients and ERNs and everyone. In a way, it was beautiful because it put, as Ilaria said, together as a community, trying to be useful for everyone. But now it has to become different, and it has to be defined, to be compensated as well, to be counted for, to become. It has to be an assessment. So this is what we're working on in Pisa and in Regione Toscana. In Italy, we have different ways healthcare is organized in different regions. So in Regione Toscana and here in Pisa, we are working on that. We're working on this system, which is, for example, an app to provide the name is Secure, and it's a secure area which will be the way to discuss with the GPs, and it has to be secured. So they are working, and our hospital manager, actually, you know him, Carlo, he's working on that. So it's really committed to this project. And so we will be working with him. We are already piloting this phase with him. And then this will be one way. I think we could have a role as networks in defining pathways and in seeing which predefined pathways, and then you will have obviously to adapt these pathways to different organizations, but then a general path which has to be followed and could be the same everywhere for GPs and HCPs, and those who are specialized could be defined. And if we do that, then patients, they will have their role as we used to define pathways outside COVID, right? So, and this will be kind of a structure, and then everyone can adapt the structure to the specific situation. So I think that we have opportunity, And we also have the obligation of do that because we are in a position where it's our role to do that. So in a way, it's an opportunity and it's something we will have to think about. So I feel that I have the I don't know how to say in English, but it's the honor and it's also the weight,
the duty,
responsibility of doing this. As I do, Ilaria feels this, and I believe all our EPAGs who have worked so much on these things with us and these organizational things, because they know that it's a big opportunity now, as it was the pathways for rare diseases. But I agree that as it was for the CTMS discussion and as it is for all these things, now that is a quiet phase. We need to understand where, how to count, how to pay, how to organize, what's the legal meaning of these and all these issues. So, and it's a work we have to do together, and the manager and the payers and everyone has to do that. We have to propose a pathway to do that, what we would like to have. And then, so I don't know. This is my vision as the coordinator of this thing. But Ilaria, please, I see you smiling. So you.
Yeah, I fully agree with you, of course, Marta. And I think we also have to educate patients to this new system, because I believe that you made a great job in these past months, but you were overwhelmed by patient requests, WhatsApp questions, and I can understand. I also understand that chronic patients, rare disease, complex patients are very anxious because they have lots of problems. So really, GPs could play an important role as the first chain of the system, let's say of the infrastructure, okay? And but also patients must understand that they don't have to stalk their doctors. It happens. No, it happens. I know sometimes we are stalkers. And also consider maybe elder people or those people that can't have access to this kind of tools.
Yes, this is a big issue. You know, what we are doing now is doing telemedicine with those who can and try to have in the clinic, those who do not have emails or phones or these things, because even though the COVID has taught to use phones, even to elder people, not everyone is really prepared to do so. So I agree that we have to also make a difference in accessibility to these tools. Not everyone has the same accessibility to these tools. This has been raised in this period for everything, for schools, for isolation, for diseases. It is not the same everywhere, even in the same city, the same country. So this has to be considered as well.
And also nurses could have an important part in this process.
Yes. So Ilaria, we have a lot of work to do.
Oh no.
You will. And I mean, fortunately, I will say that in general, talking with other stakeholders, with other people, that there is a general agreement, no? that needs to be addressed seriously. Now, as you know, the Commission recently approved the new health program, which was completely new and completely different, and that came up during the crisis. So during the crisis, it was perceived by the decision makers, the commissioners, that healthcare should be put high in the agenda. Again, in the European Union, while healthcare has been traditionally an issue of subsidiarity only, but keeping subsidiarity, keeping whatever, what is clear is that we need to coordinate things much better. And one of the elements that appears in the health program is that the European Reference Network system is a model to learn and to apply. And I think that's great, because it's not because you are not only very good in your area of expertise, it's also because the system you are working, or you probably now it's normal, it's the standard way of doing that. When we have been trying to do that with the COVID clinicians to allow them to connect, it was quite complicated. quite complicated, and it's related with everything you have been naming, the misnews, misinterpretation, all this stuff, no, about how to take clinical decision, how to organize things. So, and I am sure that if the program is approved, we will have devoted resources and much more resources to work on that. Also for the networks to develop the models, Marta, you are mentioning, to see how the patient pathways can really be applied, to work with the member states on that. So, I mean, I am optimistic by nature, but I think that learning from this terrible situation, we will revamp somehow the system also.
Yes, I agree.
So I am very sorry because we have occupied all the time talking. It's time, the time flies. It's time to close this webinar. We will, of course, ask you, because the idea is after summertime, to also with more time, with all the lessons learned about this issue, to retake this and to see how we can use all your experience to have, I mean, more evidence and more recommendation on what you have been doing. Thank you very much for your great job. So we cannot say that more times or higher or louder, because really that you did something impressive.
Thank you.
Thank you very much.
It was a pleasure. Bye-bye.
Bye. Thank you.
Thank you very much.
Bye.
Bye.